Welcome to A Blind Date with Knowledge, Series 2. We're hosting clinical research discussions across the region. I'm your host, Laura Brady. On this episode, I'm joined by the wonderful and steadfast Sharon Lance, the Deputy Director of Infection Prevention and Control. Her commitment and dedication to her field deserve major appreciation. I'm sat with Sharon Lance.
Yeah.
Hi. Can you just tell me your job role and sort of what you do on a day-to-day basis to set the scene for people who are listening?
Okay. So, as you said, Sharon Lance, I'm the Deputy Director of Infection Prevention and Control. I came into this post in September 2020 in the middle of the pandemic.
But that was a bit hitting the ground running.
Yeah. I have done infection control previously. Between 2007 and 2015.
Right.
It's a real passion of mine, always has been. I just get intrigued by the complexities around IPC. So when this position came up, despite the fact we were in a pandemic, it was too good an opportunity to miss.
And if you're so passionate about that, that's almost sort of the something to get your teeth stuck into and really showcase what you can do in that vein. So can you give a description of what that means? So what does IPC mean in a hospital environment? Okay,
so the fundamentals of IPC is to do what it says, really, to prevent transmission of infections to our patients, to our staff. So what tends to happen is when an infection occurs, when something gets into the body and causes them to increase and then develops into an infection. And usually three things are needed really for an infection to occur. So you need a source, so you need a place where the germs can live, and that can be on surfaces, it can be people, it can be equipment. You need a susceptible person. So in a hospital environment, we've got lots of those.
Many at-risk people.
Absolutely. And that's really also for a way for the germs, bacteria to enter into the body, so invasive devices, things like that. And also transmission. So the way that transfers or transmits, and that can be droplet, aerosolized.
Will be different depending on kind of what is
absolutely on bacteria, viruses, etc. So that kind of tends to be what happens.
So how does that translate on a day-to-day basis? What sort of things need to be in place to kind of keep an eye on those things? And is it in your team, sort of what roles are there?
Okay, so starting with infection control fundamentals, so we have standard precautions, so that's everything that anybody can do, but certainly when delivering patient care, so really good hand hygiene, appropriate hand hygiene, use of personal protective equipment, whatever that might be, the wider setting is understood, PPE a little bit more with the introduction of mask wearing, but other PPE includes different gowns, gloves, aprons, etc. Respiratory etiquette, so catch it, bin it slogan.
So all of these sort of campaigns you've seen crop up, I think some people now, a lot of people now are very well versed in certain ways of this, and that you've got the whole encyclopedia of the different methods.
Absolutely. But then you've got, dependent upon the way that the infection is transmitted, you've got increased PPE, etc. that can be used. So for example, if you've got a respiratory or an aerosolized infection, then you've got enhanced mask usage, such as the FFP3 masks that need to be fit tested for. So you've got those precautions across site. The infection prevention and control team. They work 7 days. They cover between the hours of 8 and 5, Monday to Friday, 8 till 4, Saturday, Sunday and bank holidays. We have an excellent administration team, and we have a fantastic group of IPC nurses that support the organisation with complexities of infections, patient flow, difficulties with isolation, prioritisation of isolation. And obviously a large part of my role at the moment is translating the guidance that comes in and making that understood, and put that in a way that people will be able to use it in their field of practice.
Yeah, so obviously you're quite well versed in doing that for many different reasons. So when COVID kind of broke out, obviously you joined like in the midst of it. But so what was it like in order to translate those requirements? What was it like chaotic? How did you minimise that, and like did things change massively? Or it sounds like you already have like a big arsenal of PPE to kind of pull from. So what was that like to translate for you?
There's a few things there. So the guidance, particularly in the early days, and probably has continued since, has changed quite radically and very quickly. With quite often getting new guidance quite late on a Friday, which is always difficult to be able to operationalise over a weekend. But certainly within the early days, we didn't really distinguish between midweek days and weekends. So although I didn't come into this post until September, I was working very much in the midst of COVID before that. I was the Associate Director of Nursing for the Community Care Centre, and I one of my fundamental roles really from the March through to the sort of the June was working in the tower block when the hospital was split. When you talk about chaotic, was it chaotic? It maybe felt like that to the outside, but actually inside it was phenomenal. You know, the teams just pulled together. The guys from procurement were in on a Saturday morning. We were loading vans up to go to primary care hospital sites, to go to community sites when you got a delivery of PPE.
It's amazing hearing everyone come together, you know, on the front line and getting their hands dirty. Well, not hands dirty, we want proper hand hygiene and all these things, just the matter of speaking.
It's like some meetings, particularly as I say, some of the community staff used to have to travel an hour to get to a meeting and then an hour back, so you're losing all of that time. And certainly from myself when I was out in the community, so a lot of my communication was done when I was driving, talking.
I know that's like your car's the office really, isn't it? Hands free.
It is. You know, all of the community teams have laptops, so having the ability to be able to log on to a meeting at their base was amazing, and you could just have a quick touch point that could last 10 minutes, or you could have a meeting that lasted an hour to get those key messages and to make sure that your teams were okay.
It's so important. So all of these procedures and policies have been like dictated by the research, and from your perspective, like how vital are they in terms of protecting the safety and the welfare of the staff? So, you know, like you mentioned just there, feeding back if something's working well, if it's not working well, and having that channel there. How is it from your perspective? How important is it to kind of receive the updates?
Our staff are our most valuable resource. You know, we can never underestimate the importance of making sure that they're okay, but also that they've got the tools to be able to do the job, but that we listen to them as well around how we move forward, because there's no getting away from it. The last 2 years have been immensely challenging for a lot of people in a lot of different ways, but research is pivotal for us to continue to develop our services, our staff, because fundamentally we need that to be able for the future for our patients. You know, we need to make sure that what we're delivering is at the highest calibre, is the most up to date, to be able to provide patient safety and ultimately those outcomes that we want for our patients. I just wrote a little thing down here around Drucker, when he said efficiency is doing things right and effectiveness is doing the right thing. And I think that's really, really important message, really, when we look at what we're doing and why we're doing it.
It is true. We can't really forget that, because they're slightly different, those things. So it seems like really everything is kind of updated like contemporaneously. There's not really a room to kind of lag behind, and it is that. But can you identify sort of any areas where you think, you know, they might benefit from a research study, or maybe tell me of a time in the past that you have like witnessed where it's been effective?
It's quite interesting that this is quite timely, because I met with Paul Baker around the MRSA decolonisation tide study that he's wanting us to support with and be involved with. And I think the importance of that is probably paramount, and could be translated across a number of areas, given the fact that we're seeing a lot of resistancy with a lot of treatment, particularly antibiotics, but other treatment as well.
Could you give like a little brief outline, just for people like to set the scene of what that trial is trying to achieve?
So it's looking at decolonisation treatment for MRSA. So we met with Paul yesterday, did a brief presentation to look at randomised control trials, to look at different treatments around reducing the potential of severe resistances as we move forward. So
you tested different methods of treating a certain or combating against this resistance.
One of the healthcare associated infections, which is MRSA. I think it'll be great. So it's very early. Hoping for to start it in the summer, and it'll probably last about 18 months. But I'm hoping that the outcome will be great, but also what we're doing along the journey and how that'll influence us.
The beautiful thing with research is no matter what you find, it will either you'll be able to implement the findings, or it will lead you to the next step, or lead you closer to a bit more understanding. And it sounds like you've got a big big staff network of passionate people who are like motivated to doing that, so it'll be easier sort of to carry that out now. Everyone's sort of primed to go,
hopefully. Hopefully. The infection control team, they are very passionate, and I think you do get that in specialist teams, but I think you get it within health. You get a certain kind of people, don't you?
You find people in those roles because they are like uplifting the safety, the welfare of the patients, but also, like you said before, the staff is the biggest resource, and you couldn't look after any patients without any staff. So we're all one together. Okay, well, thank you very much for your time.
No problem.
Thanks for listening. As always, please get in touch if you have any feedback. Catch you next time.